This is a themed podcast supported by our bronze partner, Ipsen Pharmaceuticals. Hello, Declan.
Hello, Renu.
How are you today?
I'm very well. It's Christmassy. We have a little Christmas decoration.
That's right.
In
The GUcast Christmas decorations have gone up. There's a Santa Claus there.
Santa. There's one thing, yeah. We should try harder.
But it's always festive in the studio, so we don't have to try too hard to make it Christmassy. But it's exciting times. It's really kind of holiday mode. But there's a lot of work to be done before Christmas. But we are going to focus today on renal cancer. Every
time we do a podcast about renal cancer, everyone says, do more renal cancer. We love renal cancer.
We do.
So this is a cracker.
This is a great one because I think this is a topic of great confusion, especially for urologists. Yep. And that's how do we manage metastatic renal cancer?
It used to be simple.
A bit of
Sutent, a bit of this.
TKI, sunitinib was, that was it. But we've come a long way since. It's a bit like prostate cancer. I mean, ADT was all we knew for a long time, and now that field has completely changed. And now we're talking about doublet, triplets for renal cancer.
And multiple different types of doublets and triplets. So that's the podcast today. We're going to talk about this absolutely cracking paper that's just come online in European Urology a few weeks ago. It's titled First and Second Line Treatments in Metastatic Renal Cell Carcinoma. And we've got two of the authors joining us in a few moments to talk us through that paper. And the paper itself is absolutely brilliant. We'll put a link in the notes. So if you're a urologist or anyone working in GU oncology who finds this whole thing of how are the options and what's this Len-Pem and Ipi-Nivo and this, that, the other, this is a podcast to make it simple for you. This is not a podcast for people who like really getting in the weeds. No. Euro Amigos will dissect what's going after this, but we want to make it simple.
This is
messages.
Metastatic renal cancer for dummies.
Yeah, that's exactly what it is. So we're going to walk through the paper and put the links in, and obviously we can't, replace the paper. So please go and read the paper.
Absolutely. I mean, it's a beautifully written paper, and it'll be a very highly cited paper in European Urology, published in October this year. And just the author list. It's anyone who is.
It's a hall of fame.
It's a hall of fame of renal cancer. Yeah,
it sure
absolutely.
Is. It totally is. And this podcast today is supported by our bronze partners at Ipsen Pharmaceuticals, who have cabozantinib, of course, in the metastatic space, which I see gets featured well in this paper. So thanks to everyone at Ipsen for supporting us. But should we get right into it?
Can't wait.
So it's very exciting. We've got. So let's go now, Renu, and welcome our guests joining us on Zoom from the US today. We have first author Regina Barragan-Carillo, first author on this paper, which is a cracker of a paper. She did her fellowship at City of Hope in GU Medical Oncology with Monty Pal and co. And Tian Zhang, who's a friend of the podcast, joining us from UT Southwestern. Two fantastic GU medical oncologists. Thank you very much for joining us, folks.
Welcome, ladies.
Well, thank you so much for having us.
You're outnumbered today, Declan.
Yeah, girl power here in metastatic kidney cancer. We love that. It is a hall of fame of experts in renal cancer, multidisciplinary. So superb. Regina, congratulations on putting this paper together. It was a big bit of work putting this together.
Definitely it was. And I want to just really thank all my co-authors and senior authors, and especially here with Dr. Zhang, who provided such good advice. And it was, how they say here, like it takes really a village. And what I feel especially proud about this paper is that I think at the end of the day, it's going to be a good guideline for the, as you mentioned, urologists or the everyday medical oncologists who might not get that deep into the topic of MRCC, at least to help them guide their treatment decisions whenever they're seeing a patient with metastatic renal cell carcinoma in their own clinic.
Absolutely. And Tian, last time you were on our podcast, we were still in the old studio. You were there in person visiting us at Peter Mac. We were talking about metastatic prostate cancer at the time, but good memories from them.
Yes, absolutely. It's surprising. It's been 2 years now. So thank you so much for having me back. Maybe more frequently in the future.
Absolutely.
Well, actually, that was breaking news because when Tian agreed to come on the podcast, we realized that she is coming here next year as a headline guest for the ANZUP ASM.
Yes.
The annual scientific meeting of the ANZ GU Oncology Cooperative Trial Group, which is a great meeting. We post podcasts from it every year. Right. But we were thrilled to hear you're coming next July. Is it July?
That's right, to Sydney.
Yeah.
I'm so excited to come visit you all in Sydney and maybe take a side trip to Melbourne. But
excellent.
Australia,
we'll have to do that. Come into the studio, visit us in Melbourne. That'll be great.
So it's a cracker paper. As I say, it's first and second line treatments in metastatic renal cell carcinoma. And so we thought we would you've got a lovely flow in the paper, Regina, in the way you've laid it out as you go through first and second line. So we thought we might walk through it. And again, forgive us, we keep kind of saying, well, let's make it simple, or Renu does a lot of renal cancer surgery, so she's going to throw in some examples, some pragmatic examples. So hopefully our audience will enjoy that. But in the first section, you talk about risk stratification, and I suppose that's an obvious step. And this is can be complicated as well, is figuring out what the risk stratification of our patients are. So, Regina, do you want to talk us through that a little bit as well?
Sure. Well, there have been developed several tools for us to classify patients according to risk. These tools are mostly prognostic, not predictive. And I think that's the first point I want to highlight. Particularly nowadays, we're very familiar with the IMDC risk stratification that was developed by both Dr. Heng and Dr. Tueri a couple of years back, that it takes into account both patient-related characteristics, how the patient's performance status is, whether he was diagnosed within the year and required to start treatment for the metastatic disease, and also some lab values, including, for example, anemia, increasing neutrophils, increasing in platelets, and hypercalcemia. So these tools, at least for how I put it simple for the patients, will tell me to some degree how we would expect their disease to behave, irrespective of the type of treatment we're offering. It is not the same to have a patient who was diagnosed 5 years ago and is presenting now to clinic with a new lesion than a patient who was recently diagnosed with several lesions at the time of primary diagnosis.
Yeah, it's important, isn't it? And I think just to put it in context, I mean, one patient that I recently saw is in his early 70s. He's lost quite a bit of weight. He's anemic, and that's what prompted his investigations. And he's got, this large renal mass, but he's also got multiple pulmonary nodules. He's got a pleural and a pericardial effusion. So this is a sort of situation where, you would want not only good systemic control, but also rapid systemic control. And Declan, I think as urologists, we still see these patients. I mean, we still are the gateway to a lot of these patients with renal masses. But that's a challenging situation, isn't it, Tian? And how would you risk stratify a patient like that? And where are you in terms of where you would go first?
Sure. I think of IMDC prognostication as really just a snapshot, as you sort of highlighted in a patient's presentation and disease trajectory. And these clinical factors are really an indication of underlying disease biology. So is it aggressive inflammatory disease? Is it intermediate, moderate disease? And is it more favorable, more indolent disease, right? So we're all sort of catching a patient in that snapshot and trying to figure out how aggressive and inflammatory is this tumor? Could it be immune responsive? For the patient that you highlighted, de novo metastatic disease, anemia, he has at least 2, maybe 3 risk factors if his performance status is poor. And so I would put that into intermediate to poor risk disease for sure.
And I suppose that's the way all the trials got set up with that as well. So for us urologists, there's a nice table in here which shows us what are the key risk factors that are used to create the IMDC risk groups. And it's just as Tian said, so we could get the hang of that. We have performance status, we have things like hemoglobin, calcium, platelets, etc.
And these tables are great because it also gives you an indication of how to work them up when you initially see them with a renal mass. So what blood tests to do and how to sort of try and determine what their risk prognostication it is. And it's important, isn't it? Because that prognostic indicator, the 43 months for favorable risk versus, half of that for intermediate risk. And then when we go into the poor risk category, we're now talking 8 months.
So your patient now would have been what? Dr. Ipsen, now you're an expert on risk stratification, because I'm going to ask you, what's the hemoglobin? You can make it up.
It was 100 or 10.
Okay, 10. Okay, right. So it's intermediate or poor or something like that. So we can move on now and talk about, because this whole section, this next section, Regina, clinical trials in the first line setting. And again, fantastic tables that summarize these pivotal trials and the key outcomes. But then you've got these lovely subsections, the first of which is the doublet combinations. And I think, did we count Renu? Like there are 6 different sections here. And that's why we find it confusing at the tumor board MDT meeting. Even this morning, we had a bunch of kidney cancers at Peter Mac in the MDT meeting. 6 different doublets alone in this modern era. So can you talk us a little bit through that? I suppose a bit of an overview of how we got to these doublets, and then maybe a little bit
which are the really popular ones that are commonly in clinical use.
Yeah.
Of course. So I think right now in RCC, we're having a little bit of a good problem that we have a lot of options that have not been compared head to head, but have in common like a similar control arm. So it kind of gives us an idea on how good these therapies do for patients. So actually, among all the doublets that are currently available, therefore, I would like to highlight, and why am I highlighting 4 and not all 6 or 7 that are available? Because they have the longer follow-up, because we're probably more familiar with the side effect profile. And that's like a point I will come back to later, that whenever people are going to be asking like which is the best one or how do you choose among these. So there are 3 that are among these even more similar to each other, that use a combination of one type of immunotherapy with an anti-angiogenesis tyrosine kinase inhibitor, which are the oral drugs. And also there's a 4th one that uses a double immune inhibition using the combination of ipilimumab with nivolumab. So those are the ones that are currently considered a category 1 within the NCC guidelines. And even looking more on the approval side, on the access side, probably these are going to be the combos that are available more widely spread in the world. Why it came up to be that we have very similar combinations? Probably Tian will be able to answer this question. I think it's a little bit of luck that at the time people were thinking kind of the same thing, but different groups were doing it. So that's maybe how we came up. But I would love to hear Tian's view on this.
Well, drug development is so complicated. A lot of times it is a lot of business strategy and which compounds and which companies own which compounds and have strategic alignment with which other companies. So to Regina's point, we do use a lot of ipilimumab, nivolumab now from Checkmate 214, axitinib, pembrolizumab from Keynote 426, and lenvatinib, pembrolizumab from Clear, and cabozantinib, nivolumab from Checkmate 9ER. And what I would highlight is in all of these trials, we've had hundreds to more than 1,000 patients involved on each of these phase 3 registrational trials. And yes, they were all compared against sunitinib as a control cohort, but they've importantly shown us that we can push out these survival curves, that we can get people to live longer with metastatic kidney cancer and try to change their disease biology. So these immunotherapy doublets really have changed how we practice. And I'm sure you all, Renu and Declan, you remember prior to immunotherapy checkpoint inhibitor days, the IL-2 days, we really didn't have a lot of options. And so these have really changed our outcomes and for the better for our patients.
Amazing. Actually, the patient recruitment into these trials is absolutely incredible. But Tian, maybe I'll put this to you. Do you have a favorite combination that you put against each of the risk categories?
Oh, it's really interesting. And we do talk a little bit about that in the paper, where there's a flow chart of favorable risk disease, intermediate versus poor. And I think of it as what are my goals for those patients, and what are the patient's goals too, particularly in favorable risk disease, where the patients are likely seeing more than one line of treatment. So if their goal is to really try to achieve a complete response, we might go for ipilimumab, nivolumab. If their goal is really early disease control and delaying progression, and we may go for one of the VEGF IO doublets. Intermediate and poor risk disease, I think definitely we think a lot about it being Evo up front, except for with symptomatic disease, then I tend to pull out one of these one of the VEGF IO doublets.
Very interesting. And is there any role for triplet combinations in first-line treatment of metastatic RCC?
So thankfully, we have some evidence right now from the Cosmic 313 trial that actually had a very smart design. They were the first to use as a control arm a combination with nivolumab and ipilimumab, and then as an experimental arm, they added on a TKI, which is the cabozantinib. And even though there were a little bit of increase in response rates, they really didn't notice an improvement in progression-free survival or complete responses. The only thing that was considerably higher for the patients who were receiving the triplet arm was the toxicity. And something that I was a little surprised when I read these results for the first time is that it kind of looked at the patients with intermediate risk disease favored a little bit more from the triplet combination than the patients with exclusively poor risk disease, which actually aligns with what Dr. Shan mentioned a moment ago, that there are these kind of higher risk, poor prognosis papers that probably are presenting with a more immune stimulant type of phenotype, which that's why I think are the difference that we're observing right now. But in the practice, there is no space right now for triplets.
So yeah, what I would add to that, sorry, Declan, is that, in poor risk disease, when our patients take a break, right, to Regina's point, if they have a toxicity, they need to take a break off the cabozantinib, and some of these patients did, then those patients are probably the patients that can't afford that treatment break. And so even though triplets have been tested now, not quite in vogue, I don't think they're going for that triplet approval for this particular triplet of cabo, nivo, ipi. There are other triplet trials ongoing that we're still awaiting outcomes from.
And I think why push for it when you're getting such excellent survival from these doublets and you have such an array of them to choose from. But I suppose a question that comes out of it is, what about then monotherapy, single agent monotherapy? You have a section on that here as well, Regina, because we know nivolumab and cabo together in Checkmate 9 ER, that's now a fantastic combination to use. But is there still a role for using a TKI type drug on its own, like cabozantinib, in this setting? When would you reach for monotherapy in the first line setting?
Yeah, I think it's something that depends a lot on having a very selected patient, in the sense that we do have certain patients who, for example, have a underlying immune related disease, or who are receiving high doses of steroids that could not be eligible for treatment with immunotherapy. And there's also a certain percentage of patients who do not want to start IV treatment and rather have only like an oral option. I think those are mostly the ones. And finally, at the end of the day, even though that we have several options available, there's a rest of the world where many times the access to treatment is a little more limited, and maybe the approvals change a little bit from what we see here in the US and in Australia and New Zealand. So I think that's another point to consider when selecting the therapy. What type of access are you having?
Yeah, and then to muddle things further, not only is it metastatic RCC, but the locally advanced renal cancers also present somewhat of a challenge, because these are patients we'd ideally like to do a nephrectomy on. But I had a patient recently who had a very locally advanced tumor into psoas, into the crus of the diaphragm. And he ended up having almost a year of pembrolizumab and lenvatinib as first-line treatment, and he had a good response. We saw some shrinkage of the tumor, and then we went ahead and did his cytoreductive nephrectomy, his nephrectomy really, and then he'll have a year of adjuvant treatment afterwards. But in a patient like that, and now we're sort of getting into the second-line setting, in a patient like that, if then he recurs or has systemic metastatic disease, what are his options then?
Renu, this problem, and it is a good problem to have, right? When people have good systemic control, and then they can get to what I like to call a consolidative nephrectomy.
That's a good term,
in our shop, our urologists like to do that too, once we have good systemic control of disease, or in your case, when that tumor has backed away from the psoas and you can get to clean margins. And I do advocate, if they have active disease, if they are at high risk for recurrence, I do advocate for ongoing adjuvant pembrolizumab in that setting. I usually don't continue the VEGF TKI in the adjuvant setting, but I do think there's a role for adjuvant pembrolizumab. And these people are probably the ones that are set up and more likely to recur. They're high risk for recurrence. And then to your question, then what do we do after that year of pembrolizumab, and then they recur again? I think the jury's a little bit still out. It depends on the timing of recurrence after the year of pembrolizumab. If that's pretty close, within 6 months, I would think they're a bit checkpoint inhibitor, refractory. And I would probably look for, a TKI monotherapy for that patient. If they are, out 9 months or more, and now they're recurring and progressing, we know after nivolumab treatment, there was data from about 10 years ago when nivolumab was in phase 1 trials that these T cells are activated 6 to 9 months after a single dose of nivolumab. So if they're 9 months out, and we think their T cells have been now flipped back to exhausted state, I might try to re-engage the immune system and re-challenge with these doublets and sort of restart the clock, if you will, with the frontline therapies.
Can I ask you, I remember that case. So you did an open radical nephrectomy for him. Right. So what's it like operating on these patients who've had a year of len-pem in his instance and has had a very good clinical response, probably making surgery feasible, but what's it like doing surgery in that sort of case?
These tumors are stuck. It's quite a challenge getting around them and getting clear margins. And the interesting thing is you worry that it's all disease when you're trying to get around these tumors, but in fact, a lot of it is just reactive change. And probably an element of the treatment.
Very good.
And there's a lot of necrosis in these tumors, and I guess those are all good indicators that the treatment's had effect.
And before we move on and talk about second line, Tian, a question I wanted to ask you is about pathology. That's another complicated area.
That's a good question,
They seem to change the renal cancer pathology every 3 or 4 weeks, don't they? WHO revision. But what about the patients with sarcomatoid features? I know that comes into your thinking with these. So these are mostly clear cell trials, aren't they? But what about the less common pathologies or the sarcomatoids in particular? How does that influence your decision?
So sarcomatoid in particular, I think, can occur with any histology. And I do think that we've seen the highest complete response rates in patients with sarcomatoid disease that are treated with doublets. In particular with Ipi-Nivo, there's about a 19% complete response rate from Checkmate 214 for patients with sarcomatoid subtype. Now, it's hard to achieve that in a de novo metastatic patient. So I do couch it when we're kind of seeing sarcomatoid disease and de novo metastatic disease. But these folks definitely should be thinking about immunotherapy doublets. Ipi-Nivo has a great effect. But I think if they're very symptomatic from their sarcomatoid histology, that the VEGF-IOs have a role to play as well. Now that's a little controversial in our shop. I have some colleagues who really believe in ipilimumab and nivolumab for every sarcomatoid histology that comes through. It really depends on the patient and the presentation and our goals. But Ipi-Nivo certainly has a role, and that's why we pulled it out in that flow chart to really highlight sarcomatoid features as a subtype that benefits from IO doublets.
Yeah, I mean, I think although the options seem endless and great for clear cell, it seems to be slim pickings for the non-clear cell pathologies. I mean, we recently, Declan, we were involved in a patient who had a translocation tumor of the kidney, and quite a locally aggressive one. And so when you look for options for these patients, all of a sudden you don't have many, do you?
Exactly. That's a whole other topic, and we are going to do one on renal cancer pathology and on rare pathologies as well. That's the lion's share of it, and I feel better now. I understand a bit more. I've looked at the table about risk stratification, so when it comes up in MDT next week, I'll understand. I recognize more of the doublets now, and I love the way this paper is structured into taking you through it. And the monotherapies. But let's go and talk about second line now, Regina. That's the second big section here, clinical trials in the second line setting. So talk us a bit through what you report in that setting.
It's still an area of unmet need, if I can be completely honest with everyone, because most of the information we had available until recently, until we have the TiNivo-2 data and the CONTACT-03 data, came from the time that we were using only TKIs as first line. So we didn't completely know whether we would get the same type of results with the subsequent lines of therapy. Fortunately, now with the information we have from both Contact and from TiNivo-2, is that I think at this point we come to a certain consensus that once a patient has presented a disease progression after immune-based therapy, maybe rechallenging immediately in a second line with more immune therapy might not be the best strategy, and the treatment should be selected based on several factors: how they did on the first line, the toxicities they presented, if they were receiving a TKI or not, the patient's current functional status and preferences, and also from the exclusively like from the disease side, how much response do you need at that moment? Because we have combinations, for example, as lenvatinib and everolimus, which toxicity is not nothing. It's really something that you need to be undisclosed with the patient and be very honest about. But we have other treatment options, such as, for example, the Saltifan, who has a more, I want to say, tolerable treatment profile, but maybe the time to response is going to be a little more prolonged. So I think it has to be a very active conversation with the patient on what their current priorities are regarding their treatment.
Yeah, interesting.
And it's where the monotherapy does come back in a bit, I think,
right.
again, because I know you use cabozantinib in a combination setting, but we've certainly been using it quite a bit in the second line setting as well, I think. So monotherapy comes back in a little more if you've had combo and progressed. Is that a reasonable thing to say?
Absolutely. As long as you didn't receive it on the first line, I think probably among the TKIs, right now we have the most compelling data. I don't know how you feel about that, yeah.
Yeah, cabozantinib, I think, is a great second line option. It has a lot of disease effect on its own. We have lots of patients who have benefited. And I would say if you look across the second line trials that have read out negative, they've many of them have been compared against cabozantinib as a control cohort. So it is a hard, control to beat in the refractory setting for patients who are refractory to frontline IO therapy. And I think one of the reasons is, the main reason is that it has a great disease activity for those patients.
And Tian, after Keynote 564, we are going to be entering an era of adjuvant pembrolizumab for these high-risk renal cancers. If patients recur after that, what are their options? Do you still call it first-line treatment, or is it second-line treatment for these patients? And I guess a little bit will depend on timing of recurrence, like you mentioned earlier. But how do you approach these cases, and what are their options for treatment?
Yeah, I think timing matters a lot. If they're within that 6 months, I would certainly switch mechanism of action. If they're outside of that first 6 to 12 months, I think many of my colleagues would agree that we would call it back, first line metastatic disease and re-challenge with these doublets. I think it helps patients to sort of frame it of, hey, you've had really good adjuvant treatment, and now, a year later, and maybe more, we see, late recurrences too. Now you've recurred, but we're going to rethink about you as, frontline management. So I tend to think of it as, how distant is it from their adjuvant treatment? Could we, re-engage the immune system and use frontline approaches again? If not, then, cabo, I think, is a great option if they're recurring very closely to their adjuvant treatment. Cabo is a great option. Regina highlighted belzutifan as a single agent, and for many of the sort of VHL-driven tumors, I would say, those are the ones that belzutifan works for. Now, when we think about belzutifan in that refractory setting, the LIGHTSPARK 005 data, there was some crossing of the curves for PFS. And I think there are patients who are set up to respond well and have that plateau. But there are also patients who are early refractory to belzutifan. So I would love to see some biomarkers so that we can find the right candidates who are set up to respond to belzutifan.
We're going to do a complete podcast on belzutifan, aren't we? Because that's relatively new for us, Tian and Regina, and we're just getting it on an access program in Australia for our VHL patients as well. But it's a really interesting drug, isn't it? Yeah. And again, it kind of caps off.
Sorry, the precursor drug was actually discovered here on campus, here at UT Southwestern. So we love to brag about, the HIF2 alpha inhibitors. That's right.
Excellent.
Peloton was spun out of one of the labs here, and then it was bought by Merck, and then it became belzutifan. But it's an incredible story, bench to bedside for sure.
Wow.
And so I'll be first to listen to your podcast when to record that for belzutifan.
Well, you might have to come back on, and you're right to brag about it, because these unsung heroes doing bench to bedside work with so many negative things and so much heartbreak and so difficult to get grants. This is not coming from big pharma. This is started in the lab and then gets taken up. So a great story, but it's a very interesting product, isn't it? And I know many of our listeners will want to hear more about belzutifan, but it's interesting seeing it coming in the non-pure VHL population. I suppose like the original TKIs did. And I look at that thinking it's capping off an amazing 10 years of progress in renal cancer, when all we had 10 years ago was the TKIs, which was exciting at the time, because before that it was just the ILs. And it's an amazing 10 years, and adjuvant pembro in that setting as well. But the last thing we wanted to pick your brains on, Regina, and it's not a big focus of the paper, is what about things like metastectomy and things like SABR to solitary disease? Because we do have lots of those patients, Renu, who've had surgery in the past, and they've got this late kind of oligo recurrence, and they're asymptomatic, and we're turning around and showing the scans to the GU Medonc team saying, no, we're not going to offer all of our thingies here. They're not quite ready yet. Yeah. So can you talk to us a little bit, Regina, about the role of metastectomy or sort of metastasis-directed therapy in this paradigm as well, maybe before or in between systemic therapies?
Yeah, definitely. So I think one of the major questions we have to ask ourselves before starting any line of treatment is whether it is the right time to start. We see in clinic many of these patients that present with what we would call similar like a low burden disease, low risk, maybe only in the nodes, or maybe a single or a couple metastases in the lungs. And there's this paper that was published in Lancet, if I recall correctly, in 2016, that was looking on the timing of when to start systemic therapy, and actually identified these lower risk patients that we could wait until we consider it necessary, for example, more lesions or a different distribution, and then we can start. I see a similar type of approach in the sense that whenever we encounter these patients and we don't want to make them start the therapy, they're going to end up probably using the rest of their lives. We try to make this type of different interventions, either with surgery or with we have right now coming up a lot of information coming from SBRT as an option to be able either to cure it if it's, I think, in the better case scenario, or at least avoid the patient from a toxicity from a treatment they're going to be needing for the rest of your lives. And even though right now we have very nice options available, at the end of the day, there's going to be always a need for better and more therapies with lesser toxicities. And I think at least the least thing we can get from this is they buy time.
Mm-hmm.
Love it.
So you can delay systemic therapy there. It's interesting.
So we still have little jobs to do, surgeons. We still chop out a bit of it in between times. But it's an amazing era for renal cancer patients. Absolutely.
And Tian, I guess the last thing before we wrap up is, treatment de-escalation, giving patients treatment breaks, because these drugs, as wonderful as they are, they also have toxicities. And how do you approach this when you see a patient in front of you in clinic? If they're tolerating it well, do you really rely on imaging findings to determine when to give them a break? Or are there other parameters that you look at?
Yeah, I think especially the VEGF TKIs, many years of treatment on these agents can have probably cardiovascular effects in the long term. And, we manage hypertension aggressively. We manage a lot of these things, but I'm not shy to give a treatment break or to dose de-escalate if side effects become really challenging to deal with. Many of our patients deal with diarrhea, hypertension. They're fatigued, and so I am one to as they are stable on treatment for a longer term. I'm one to really think about could there be some treatment breaks, treatment holidays, and give them a break from those side effects because they can be tolerable, but they are a nuisance, right? For our patients to deal with day in and day out.
There we go.
I love it. I love it. This was a fantastic episode. I know this is going to be much loved and shared. And by the way, that algorithm figure 1 that you've got in there, Regina, we'll push that out on socials as well. But that should be, you should save that in your phone. It should be, that lovely algorithm of management of first line in there. And I'm going to do that so I can, show off in the MDT next week. I can drop in stuff and Ben and Lewis and Lavinia will be going,
they'll be very impressed.
Where did he learn that? Has he
done a podcast on this,
Cancer for Dummies? Yeah. But thank you so much.
Thank you so much. And Tian, you're gearing up for SUO, which is in Dallas this year.
Yeah, this week.
That's exciting this week. Yeah.
Yeah, no, we're welcoming a lot of our uro-oncology colleagues here to Dallas. So, so to see them. Yeah.
Brilliant.
That's great. And Regina, I know your plan is not to stay around in California forever. You're from Guadalajara and you're going to get back to Mexico at some stage, I think, aren't you?
Yes, I'm going back home to Mexico City in around 3 to 4 months. I'm still dealing with my parents regarding leaving the best team, what I think, and leaving my boss, Dr. Pao, here. But I think it's important, at least for me, in a personal level, to be able to give back to my country and to my community. And actually, having worked with amazing people, just as Dr. Zhang here in the call with us, have given me the opportunity to be able to give back to the med-onc community and the patients back home.
Wonderful. Monty would be so proud of you.
He would. Yeah. And he's such a good mentor. He's got really a big reputation. And nothing makes people happier than disseminating that knowledge and experience so lots of other people benefit. So it's very worthy and very great. We've got a Mexican fellow coming next year, actually. Carlos Delgado. And he's at the National Cancer Center in Mexico. So we'll have to connect you two together when he goes back from Peter Mac next year.
Absolutely.
Oh, I would love that. I would really appreciate it.
All right.
Thank you so much for your time.
Yeah, that was amazing, Renu. Did you enjoy that?
It was a great masterclass in
metastatic renal cancer. It was a masterclass. And the thing about that paper is it will need to be updated in 2 years' time.
That's right.
Again.
So it's a very, Regina has more work to do.
Yeah, so when this gets 500 sites in 2 years, Briganti will be saying, again, where's Regina now? And Tian and Chueri and everybody.
Fantastic.
But it's a beautiful paper. We hope you enjoyed that. Thanks again to our bronze partners, Ipsen, for supporting this podcast and for supporting other educational activity we do. That's all we have time for now. We'll be back again soon.
Very soon.